And 3, 2, 1. Good afternoon, everybody. This is Dr. Cedric Spock, infectious disease specialist, coming to you again with coronavirus, uncut and updates, I guess we'll call it this one. And this is the third in a series of irregular updates. I am doing this in the trauma conference room, and I am alone. So we're doing our social distancing, and kind of like the last video, I take my mask off. If you do it, make sure and take it off front end and then set it aside, and then don't touch it on the inside, as we're all trying to figure out how to navigate our days through PPE. We are now approximately 3 weeks into the coronavirus pandemic. And we've heard the word pandemic before, and it almost sounded like it was it's just another rainstorm or snowstorm. Let's just kind of move on. And this is really being something different. And lots of intelligent questions are being asked, lots of scientific and clinical questions, lots of political questions. And this update is to sort of touch on a lot of these things. Remember that I'm a clinical infectious disease specialist. I am a clinician. So I'm a clinician providing updates to clinicians. And this is my interpretation of a lot of things, looking at historical details as well as how things are moving forward. I'm not being a voice of, say, anything official. So I'm not working for the CDC. I'm not working for the WHO, although everybody is working very hard at trying to figure these out. And sometimes we feel like people may have been able to do better, but I don't think it helps to really look back and criticize what had been done. Instead, I think we need to be objective and try and learn from all the experiences that have occurred already. Questions that have been brought up over the last week are very different than the questions that were brought up 3 weeks ago. 3 weeks ago, the questions were, well, is this going to be a big deal? Do we really need to worry about it? What do we need to really think about if we're talking about flattening the curve? Now the questions are more clinical. How do we make a diagnosis? What do we do when we see the patients? How do we treat them? And yeah, we kind of touched on these earlier. Remember that none of us are an expert. We're all in this together, and we're all learning about this together. And as we're learning about this together, we're actually all going to become experts. We're all going to have our own experiences. We're all going to develop our own biases. And that's part of clinical medicine. Clinical medicine can frequently be very messy. We will have our own successes. We will have our own failures. With this, we will be teaching each other. We'll have observations. Hey, did you see the way the labs changed? Did you see how that culture was? Did you hear about the one that was false negative that became positive? And that's part of the issue as well. Over the last 2 weeks, a lot of recognition has occurred about the disease and how there are different manifestations of the disease. The description had been asymptomatic and symptomatic. Now it really appears to be a sort of an asymptomatic phase, there is an indolent phase, and then there's a symptomatic phase. And so there does seem to be a sort of a trimodal distribution of illness. This is not something we're accustomed to. When patients present with these subclinical signs, we're learning that they don't always have fever. They may have GI symptoms. The GI symptoms can be common. And so we'll all end up seeing patients that will have to talk to them, and we'll see the official recommendations, and we'll recognize, actually, a lot of my patients could actually have coronavirus, even though I didn't think so originally, because we know it's out there in the community. So GI symptoms can be included. They've also talked about ocular symptoms. There are reports of, it's almost like a raccoon eye, or alternatively a subconjunctival eruption. These are different things that we see in multiple viral illnesses. So pediatricians are more familiar with this than the rest of us. They'll talk about a viral syndrome. As the virus continues to go across the population, we will continue to see different manifestations of disease. I think the most important thing is risk stratification. 2 weeks ago, I tried to bring this up and kind of tried to talk about it. And then we took a week break, and actually additional information is coming from New York experiences, Seattle experiences. What can we really use at the baseline to help us recognize which patients are going to be sicker? Lymphopenia was recognized as one of them. Elevated D-dimer is also another one, elevated ferritin. CRP, C-reactive protein, which is a test that we've had for decades, does also seem to be useful. There is a lot of interest in checking interleukin levels, interleukin 6. Unfortunately, this is still a send-out test at most medical centers, including this one, and so it's not coming back as quickly as we'd like. Chest x-ray, hypoxemia, those things are also helpful, but we really don't know what kind of chest x-ray. So we don't know if they have an infiltrate, can we determine how sick they are? But it does seem that if they have an infiltrate at all, they're already sicker. When the disease occurs, how long does it go on for? Well, 5 days is what we were saying, and now we're still saying, yeah, it's probably 5 to 7 days, but we're also recognizing that some of these patients may have a delayed phase. When they have a delayed phase, how long will they be sick for? Will they be sick for a week, 2 weeks, a month? We don't know. What do we do when we send the patients home? We think we put them in isolation. Doctors are calling other doctors, calling other specialists. Do we put them in isolation for 7 days, 14 days? Can we do a test of cure before we take them out of isolation? These are also good questions I don't think we can answer yet. The official recommendation is 7 days in some places, 14 days in others. In other places, they're saying we should do a test of cure. Testing is coming. We are having more testing. We're having more availability of testing. Lots of people are working hard at making sure that's available. There are also reports of some false testing, some people that are creating drive-through clinics in other places in the country have been reported to actually not even provide the testing. I haven't really heard of that here in the North Texas area, but it may be a case. So if a patient says they have a positive test, it's always good to get the result. Do you really have a positive? Transmission. Let's change gears. All of us as clinicians need to recognize some of the implications of any epidemic. When an epidemic happens, there's 3 elements of an epidemic. There's transmission, there's illness, and then there's recovery. But recovery can actually be in an epidemic the same as death, because obviously a deceased patient can no longer transmit the disease, although we're actually so worried about this disease that the official recommendation is that any decedent should not be a recipient of an autopsy because the transmission is still not known there. So going back to the epidemic, if you recognize that the 3 elements of an epidemic are transmission, disease, and then recovery, the one thing that can definitely be impacted with the public health measures being done right now is transmission. If transmission goes to 0, then all that remains is going to be those that are sick and those that recover. In theory, if transmission can be reduced to 0 for a period of time, then the epidemic can be discontinued. This has been studied in other epidemics. 10 years ago, mathematic modeling showed, for example, with HIV, that if all human beings were put on antiretrovirals, and if all human beings took the antiretrovirals, transmission rates for HIV would reach 0, so that HIV could be successfully eradicated from the human race. Because the observation was, there is no other reservoir for HIV. It is only in humans. Well, that's an interesting thing to think about this coronavirus infection. Is the coronavirus infection only in humans? We don't even know that. There are now media reports of it being seen in animals. There was a famous headline just a few days ago talking about a tiger at the Bronx Zoo. I get calls about that. I don't know how to interpret that. I don't know if the tiger that has coronavirus is now going to infect other people. And so I think it is important to follow what Dr. Tony Fauci is doing and to be comfortable with telling each other and the patients, I don't know. What can we learn from other epidemics? What are the things about this epidemic? Well, there's been a lot of talk about we need additional testing and we also need serologic testing. And if we have serologic testing, it'll help in the control of the epidemic. The assumption is that we have serologic testing, that serologic testing guarantees that the individual is immune. We don't have those scientific data either, but serologic testing is coming. There will be serologic testing in the next few weeks and certainly will help us as we're making these approaches to taking care of these patients. And so I wouldn't say, oh, just because we have serologies, we can't prove that you have immunity, but instead it is a step in the right direction. And so there are some discussions that if we had serologic testing, that then the serologic testing would be useful, and that maybe we could then provide that as a way of referring individuals to say, all right, you are not able to get sick, you are now immune. When the coronavirus is being studied, realizing that there are new elements of this disease, and also recognizing that as the scientific knowledge is advancing, another way I wanted to help the audience is to consider, where do you get the information from? You know, if we just get the information from the media, yes, that may be real-time information, but unfortunately, it is not necessarily clinically relevant. And then the opposite is if we get a published journal article, well, that's great, but the published journal article is peer-reviewed, which means it took a lot of time. So where can you get more information? On the internet, there is a lot of information. I think several sources that are worth looking at. First of all, the University of Washington has an outstanding resource that is being updated on a weekly basis with additional documents to address a lot of the questions that clinicians have. Clinical questions about treatment, infection control, what to tell families, what do you do about healthcare workers? It's all there. And I actually checked it last night, and I checked it several ways. I just Googled University of Washington coronavirus, and it's right there. I went to the Infectious Disease Society IDSA website, and they have links to it as well. And I've posted those links on social media myself, on LinkedIn, to share it with other people. And so that is a valuable resource. A lot of intelligent people are getting together to put information there. On there, they actually do address the question that we're all wondering. What do we do when we get the patients in the hospital? You have a patient with a confirmed COVID. Okay, so now we're going to have a lot of patients. How many are we going to have? Lots of estimates. Some of the estimates are frightening. It sounds like the estimates for here in North Texas are not as frightening as they would have been 2 weeks ago. It's as if we are successfully flattening the curve, and therefore the surge that has been described will be more manageable. But it'll still be all hands on deck. A lot of people will be working on these patients that aren't necessarily accustomed to taking care of critically ill patients, and a lot of our associates may be helping in other parts of the hospital so we can focus more on these critically ill patients. How long will this go on for? Will this go on for a week, a month, a year? Is it going to come back? Once again, don't know. Is next week going to be worse than this week? Well, that's what a lot of the experts are saying. I don't know if that's necessarily true, though. You know, every day we hear about patients. Some of us are now seeing the patients, and some of us are seeing the sick ones, and some of us are seeing the not so sick ones. The other thing that we're dealing with is, how do we rule out the patients? You know, if every patient is suspect, do we need to rule out every patient? I don't even know that, because we're all now getting anecdotes of patients that we thought were asymptomatic that are now positive for COVID-19. So is that what's going to happen? Maybe. Hospitals trying to figure it out. Epidemiology is trying to figure it out. Infection control is going to try and figure it out. So yes, it does change every day. What other sources can you get on the internet? Well, public health authorities, WHO and CDC, were the usual sources of information for things like influenza. Unfortunately, it seems like those websites are a little behind, and sometimes that happens too. What about social media? You know, people are getting information off Twitter. People are getting information from other clinicians, people that they know, friends from school that are working in New York or Seattle. That probably does help. It probably helps to have a one-on-one conversation with somebody you knew from previously, but that is anecdotal information. That's not public information. New England Journal of Medicine does have a good website. They are updating it. They, for example, right now are starting to publish a lot of the data from Korea, as well as from Washington State. They updated information on the outbreak associated with the nursing home. I encourage you to look at that, and you can see the breakdown in patients who are symptomatic, and then also the healthcare workers that become symptomatic. You can also see that they're starting to report data on Korea, and there they have widespread testing and are recognizing the spectrum of disease is quite diverse. What we really need to know is to predict who's going to be the sickest. Boris Johnson is in the ICU in London. Could that have been predicted? That's a tragedy. How sick is he? I'm not his doctor. I don't know. I see it on the BBC News. probably going to bring this up to a lot of people's attention. With this disease, when we see the patients are nervous. That's different. You know, we all take care of sick people in a variety of situations: trauma, myocardial infarction, pneumonia, respiratory failure, et cetera, et cetera. And when we come in and we see them and we have our teams, there are always people on the teams that are familiar with what's going on. Oh yeah, we can take care of this. And now the patients are realizing if we say you don't know, they're nervous too. I think it's actually okay. Once again, going back to Tony Fauci, like, hey, we're working on this. We're trying to figure things out. They ask you questions. You know, you may get stopped in the hallway. Recognizing that since we're all in this together and we're all experts, we're all going to be asking each other a lot of questions. You're going to get stopped in the hallway. Hey, what do you think about my husband at home? Is he at risk? He's got asthma. And they say, I don't know, that's a good question. Where can we get that answer? You know, hey, how are you doing your hygiene? Are you taking a shower? Are you using the guest room? Are you sleeping in another part of the house? These are all big conversations that are happening right now across the medical center, not just here, but everywhere in the United States and beyond. We aren't going to get those answers yet because we're looking at that. If you go look at the New England Journal and say, hey, what do I do about my spouse who's got asthma? You're not going to find that information. Instead, you're going to find the, wow, we've got individuals who can be symptomatic modestly or not at all. Another thing about epidemiology, though, when you look at the data, and what we definitely know, is that whenever the epidemiologic data are reported, the reporting is limited by the testing available regardless of what the disease is. So when they're talking this morning about what's going on in Suffolk County in Long Island, and they're talking about the number of deaths is one way to describe the epidemic. Another way to describe the epidemic is the confirmed deaths. So you actually have those cases that are confirmed. In the middle are all the suspected cases. And the suspected cases is why we still can't give an intelligent estimate for case fatality rates or even attack rates, because we don't have universal diagnosis. And so we hear about these, and we hear about these surges in deaths. We're seeing it in different regions. Dr. Fauci states that what we're certainly going to see with this disease is regional variation. So at the grassroots level, the experience that we're going to have with coronavirus in North Texas is going to be different than the experience in New Orleans or New York or in Wuhan, China. Every region will have its own different experience because of all the other variables: population health, what kind of implemented strategies were made to mitigate the spread. Different counties are doing different levels of mitigation. And so how will that affect things? You know, Dallas County is different than Tarrant County, which is different than Collin County. And so we probably are going to have a heterogeneity of the disease across the Dallas-Fort Worth area. And so I think we can learn from each other. So if we're talking to our colleagues in different hospitals even, we can teach each other things. And so I encourage all of you to try and be scientific and objective and say, all right, you did that and it worked, or alternatively, you did that and it didn't work. With other epidemics, the fear is real. The fear was real when HIV came to the United States in the 1980s. And when the fear was real, there was lots of misunderstanding. We can learn from those historical lessons and then use it to help us today. So for example, when HIV was first described, I'll give you a little background for those in the audience who aren't familiar with HIV, recognizing that a lot of the people listening weren't actually even practicing back in the 1980s. In the early 1980s, when HIV was first really spreading across communities, there was no test. The test, when it first came out, was a hand-done test called the Western blot. And it was done by hand, so it took time. So to actually get a confirmatory result wasn't an instant turnaround. So then the clinicians had to establish a diagnosis based on history, risk factors, and then clinical bedside assessment. They came in, they had HIV, there was wasting, there was thrush, there were other manifestations. They look at the laboratory studies. They had low lymphocyte count, low albumin, proteinuria, all of these objective metrics we could check. And then remember, They would have complications from their HIV infection that we were also learning about. So initially, we didn't know that if there's an outbreak of pneumocystis in Los Angeles in the early 1980s among professional men who had no risk factors for immunodeficiency, but they all were identified as men who had sex with men. So then the original description for AIDS wasn't even AIDS. The original epidemiologic case definition was the gay-related immunodeficiency, GRID, and that was in 1981. And that was before the test. And then in 1982, in New York, individuals from Haiti who were not gay also were found to have similar symptoms, and they also came across injection drug abusers. And so it took public health authorities, scientists, molecular biologists, infectious disease specialists, several years to establish the syndrome, which was then called AIDS, acquired immunodeficiency syndrome, and then the causative agent, human immunodeficiency virus. The human immunodeficiency virus was discovered. It wasn't called human immunodeficiency virus. Its original name was the human T-cell lymphotropic virus 3, HTLV3, because it was a retrovirus, and it was the third retrovirus that had really been discovered after HTLV1 and HTLV2. And so the nomenclature had to be changed when it was recognized that it was the causative agent of AIDS. Remarkable. This is exactly what we're going through right now. 6 months ago, it was called the Chinese virus, the Wuhan virus. It was called the coronavirus. And then the scientists really started looking at it and said, no, we have to call it COVID-19, which stands for coronavirus disease 2019. And so that name is the scientific name, just like the name for somebody who has symptomatic HIV infection has AIDS. But this didn't all happen immediately. It took time. And so I think that's the way we need to recognize what's going on here, is that we're in the midst of this, we're experiencing it, and the scientists and the clinicians are working together in and out of the hospitals to define the illness. In the 1980s, every single doctor took care of patients with AIDS, and so they became experienced in multiple ways. In the 1980s, the leading cause of blindness in the United States was cytomegalovirus retinitis. It wasn't glaucoma. It wasn't macular degeneration. So ophthalmologists who for decades were accustomed to treating disorders of the eye all became experts at CMV retinitis. Today, our ophthalmologists don't see CMV retinitis. It's now a historical footnote. It's forgotten about. It's in the chapters of the ophthalmology and infectious disease textbooks. Perhaps once a year we'll get a case. We'll call each other, talk to somebody. So that's the way this decade's going to be. We're going to learn a lot about COVID-19. We're going to learn a lot about coronavirus. And as we learn about it, we're going to then talk to each other, and each specialist is going to get to know this disease in their own way. They're going to learn elements of the disease, whether it's going to be the cardiac manifestations that have been described by some of the original descriptions in China, or if it's going to be the radiographic findings that we see on CT scans that our colleagues in chest radiography are now helping us with. What about diseases of the airway? Remarkable how we're seeing an explosion of different ways of intubating people. All of these really innovative anesthesia and critical care specialists, so much so that actually on the New England Journal website yesterday, they now have a video on how to put a glass cube around the patient's head so that they can be safely intubated. And then what they did is they showed the way the droplet precautions come up and hit the intubator in the face so that when you do the glass cube, you can actually minimize that exposure. And then they have a whole video telling you how to build the glass cube. Okay, that's very different than AIDS, because when AIDS was happening in the 1980s, we didn't have the internet. And people were not uploading videos to be looked at other medical centers in the middle of the night so they could then share knowledge with each other. So we have come a long way, and I think we should take advantage of these technologies. When we think about those things with sort of the innovations and sort of how do we move forward, we're also going to make some mistakes. And we got to remember that. And we shouldn't insult each other when we make mistakes. So that we'll say, oh, wait a minute, the glass cube, maybe it didn't work when we used it with a kind of plexiglass, or maybe we need to, I don't know, like we're going to learn more about it. There was an amazing story that was published in JAMA this weekend talking about droplet precautions. And I grew up as an infectious disease physician 15 years ago. I always knew about droplet, and we talked about airborne, and we knew about droplet with influenza, and we talked about varicella, and we knew about tuberculosis. And so, for example, with tuberculosis, there's all these seminal studies that were done on guinea pigs that were given tuberculosis, and then they put guinea pigs into different squares, and then they attached the squares with hoses, and then the guinea pigs were measured to see how many guinea pigs got TB from the guinea pig that had TB. You guys are listening to me right now patiently as I talk to this little camera. And you're like, where's Spock going with this? Well, the reason I'm saying all this is we got so into the weeds with tuberculosis that actually in modern language, guinea pig, so you're going to use me as a guinea pig, comes from TB research, because it turns out that the animal model for tuberculosis is the guinea pig. We can give Mycobacterium tuberculosis to guinea pigs. And then with guinea pigs, we learned how guinea pigs could infect other guinea pigs. So then using those animal data, we were able to help the hospital so that we would reduce transmission of tuberculosis from one patient to, say, healthcare workers, or alternatively to other patients, because we didn't want to have a nosocomial tuberculosis outbreak. That would be very bad for obvious reasons. So when they looked at the guinea pigs, they actually took a guinea pig and then they put 20 guinea pigs, and then they put them in different rooms with different lengths of tubes, and then they put them at day and night and ultraviolet and other things, and then they determined how many guinea pigs got it. And they actually determined how many individual tubercles of tuberculosis were needed to transmit over a certain distance. We actually know those kind of data for just about every infectious disease. We define the infectiousness of an infection so that we can predict, for example, going back to HIV, getting HIV from one sex act is not a 100% thing. It actually takes multiple sex acts to acquire HIV. Based on population data, we know how many sex acts are needed to transmit HIV. We can then give a risk stratification based on individual sexual behavior. We can't do that with coronavirus. So that unknown certainly makes us nervous. You know, we all kind of walk out of the hospital now thinking we're covered in a coronavirus cloud. You know, I got my COVID cloud like Pigpen on Charlie Brown, and I gotta kind of scrub it off me. Of course, it's not really what it is. I can't see the coronavirus around me, but we do worry about that. We worry about it also because healthcare workers are getting sick from this. And so we are healthcare workers. We're in the trenches, and we don't want to get sick from this. We want to be able to take care of our patients. We want to be able to be healthy. We want to be able to come home to our family. And we actually like coming to work, and we don't want to be scared coming to work. There are headlines now about nurses and doctors scared to go to work. Well, why are they scared to go to work? Well, they're scared to go to work because they're trying to figure out if they're going to get sick. Back to those other historical examples, like the guinea pigs. When we're learning this stuff, it is noteworthy that that viruses aren't necessarily as infectious in smaller quantities than in larger quantities. Bacteria are actually the same way. There have been studies that have shown that if you inject E. coli into a bloodstream, that human being does not get septic. That was before IRBs really clamped down. Can you imagine the medical students that are being recruited for studies in the 1970s? Hey, I'm going to inject some stool into your femoral artery. But that actually was done. And they found that certain amounts of E. coli didn't give you endotoxin-mediated septic shock. Oh, we're not going to get that kind of data. We're not going to put med students over in the COVID hall and see how many of them end up developing coronavirus. But do we have ways to measure the quantity of the virus in the air? We don't, but we're probably going to get it. We're probably going to have those kinds of innovations. Makes me wonder, are we going to have an innovation where on my phone, I'm going to be able to walk into a room and measure the percentage of the virus in the air? I don't know. I bet there's a lot of smart people that are trying to figure it out, especially now that they're all forced to stay at home. And I think those kinds of testing will help us, because it is clear that if you're intubating a patient without any protection and you didn't know they have coronavirus, your risk of acquiring coronavirus is high. So now we're trying to figure out ways to minimize it, going back to the New England Journal and looking at the cube. And when we look at the cube and the way we're reducing it. And so risk reduction is what we're trying. We're not risk prevention. No different than wearing a seatbelt in the car, no different than wearing a helmet when you ride your motorcycle. All of these things reduce the risk. And so wearing the N95 mask, wearing gloves, wearing PPE, and then that's an ongoing discussion that, yes, we have to deal with the practicalities of how much PPE we have and what do we really need. And then, going back to the guinea pig, where's that animal model? Do we have an animal model for coronavirus? Well, not yet, but we'll probably get it. You know, we think it came from bats. So does that mean bats are an animal model? Is it going to be a different animal model? Going back to the stories of the dog or the tiger, are those animals that are getting coronavirus and are being somewhat symptomatic, and can they be studied? Maybe they can be studied. So infectiousness is an ongoing conversation, because then within the media, they're talking about, oh, wait, so-and-so got off the cruise ship and then somebody swabbed his rectum and his rectum still has coronavirus 29 days later. And then there's like concern. Well, wait a minute. We didn't actually prove that that virus is still viable. Is it just RNA fragments? Is it digested virus? You know, there's lots of questions about that. With the audience, the last thing to wrap up, because you guys have been very attentive and I want to make sure and leave time for questions. When we diagnose a virus, remember that diagnosing a virus is very different than diagnosing a bacteria or diagnosing a cancer, and that we have different levels of visualization. The original way to describe a viral infection was with what was called a viral culture. And what had to be done is there had to be a lot of viable virus, and that viable virus then had to be put into a culture, and then the virus had to successfully grow in a laboratory, and then you couldn't see the virus. You had to look for proof that the virus was there. It starts sounding like something out of like atomic physics. Like, you don't see the neutrons, you don't see the protons, but you know they're there. How do you know they're there? Well, these are called indirect methods. So when you do a viral culture, you actually, after growing the virus successfully, the virus is a pathogen, so it should be able to kill things. So it'll kill cells. So you can see the cells are dead. Well, that's labor intensive and can really only be done in a skilled laboratory by skilled laboratory technicians, and we don't do that. The testing that they're talking about now is PCR, which is a technology that was developed in the 1980s. When HIV was first being characterized, the original testing was serology. So we're doing it backwards. We're doing PCR and we don't even have a serology yet. The Western blot for HIV was serology. Today, we don't have serology for coronavirus. They're saying it's coming. Instead, we're going straight to PCR. When we were doing PCR for HIV, it took 2-3 weeks to get the results because it was all done by hand. Now we're automating it. Well, in the middle, there's all these other ways of diagnosing viral infections. And there was an evolving methodology using additional indirect methods. Because remember, viruses can't be seen. And that's part of the reason we're nervous, because we can't see the virus. You know, we see a patient with lung cancer, you never walk in the room thinking, I'm going to get lung cancer from that patient. You walk in and you see a patient with Staph aureus bacteremia. Yes, you wear contact isolation if they have MRSA based on current guidelines, but you don't think you're going to get MRSA. And actually, typically, you see the sequela of the infection. You see the furuncle, you see the abscess, whatever. But when they have virus, You see the chest x-ray, you know they've got an infiltrate, you see the symptoms. So once again, you're seeing all the indirect effects of the virus. So clinically, we're making the diagnosis, even though we get the PCR, which is confirming the diagnosis. And the PCR is counting the amount of virus. But the PCR we're having right now is not actually quantifying the virus, it's qualifying the virus. So we have a binomial result, a positive and a negative. So it's like a pregnancy test. Wouldn't it be interesting if in the next few months we have different levels of testing? Like, oh, you have a lot of coronavirus. You have 10 zillion coronavirus as opposed to 10 quadrillion. You know, there are things that I think are going to happen as we define this disease. I keep going back to HIV because in my experience, in my career, that's when my career started, and I remember the fear there. And I remember when Princess Diana hugged an AIDS patient at hospice on TV, and I remember people talking about it and saying Princess Diana was crazy for doing that. And now fast forward and we've got the fear again. So human beings get scared of infections. We've been scared of viruses before. And then now they all say that the virus we know the best in the world is HIV. And actually HIV, it's still a serious disease, but we actually do know it well enough to control it so that AIDS is not what it was. So I'm kind of jumping around so that you guys can get the benefit of sort of historical perspective. As a clinical infectious disease specialist, I've seen a variety of these things. When I'm talking to the patients now, I think it's really important to tell them, we're doing everything we can to help you. We're trying to figure things out. You have to listen to them if they express frustration about testing turnaround or not being able to get testing or the testing that they had to wait for at another place or et cetera. But I don't think it helps them if we sit there and say, yeah, you know, the system's broken, or yeah, you know, no, it's coming together. We're learning more about this virus in the last 16 weeks than we've learned about any disease ever in the history of medicine. And we're still trying to learn. And so I'm always trying to think of glass half full. We're coming together. Look at what we're doing now. We're doing these interactions coming together. So when we're talking to the patients, we should be honest. We should be able to tell them. And then when it comes to treatments, so I've been asked, hey, can you talk about treatments? And I was like, you know, that's another conversation, and that is an interesting conversation, but it's an awfully hard conversation to have because we're generating the science right now. And that's what we're going to talk to each other, you know, because the disease is teaching us that it's different. You know, steroids, yes. Steroids, no. You give them an anti-malarial, you give them an antibiotic, and you give them an anti-parasitic, and these are all antiviral. What? Are they going to make fun of us 10 years from now because of that? I don't know. We need to see the clinical data. We really need to see good randomized data that we don't have yet. So we're trying different things. And, oh, wait a minute, we're giving different immunosuppressive therapies. Oh, I'm going to use an IL-6 blocker, or I'm going to try other immunomodulatory agents. Once again, interesting. We're actually defining cytokines. When I was looking over last night, trying to get ready for you guys today, I don't think I can provide definitive recommendations on therapy. I am having interesting conversations in the hallways with my colleagues about this. And I'm hearing my colleagues also thinking. And actually, that's what we're good at. Most of us, we're trained to think. So we need to think. We need to think, all right, what am I doing about this patient? Wait a minute, I read that sometimes these patients get hypercarbic because they have microemboli, so that means I need to heparinize them. So I'm heparinizing a pneumonia? It's not a PE. Really? Yeah, I guess it makes sense. How am I monitoring? I don't know. Am I getting daily D-dimers? Hey, what did you read? What did you see? And so we're going to talk to each other. Hey, should we give them antibiotics because they're having fevers? I don't know. Hey, should we give them this anti-malarial? I don't know. And as we move forward, I think it's good for us to lean on each other. And as always, I appreciate the effort to reach out to you guys. And so I'm going to go ahead and change gears and leave time for questions. So let's see if you guys can shoot me some questions, either on my cell phone or because I don't think I can see the screen. Got questions. So this is a question, and actually I'm going to, sometimes I'll tell you who asked the question. This is from Dr. Rabler. Thoughts on the need for suppress and lift cycles of controlled periodic viral infection surge until a vaccine is developed or most people have contracted COVID-19. Tony Fauci pointed out that coronaviruses don't infer lifelong immunity. So if we don't have lifelong immunity from a coronavirus, can you have a vaccine? We don't know. And so how are these cycles going to go moving forward? You know, some are saying that we're going to get into the warmer months. The warmer months are going to be easier. And then in the fall, it's going to be worse. The only reason they're saying that is they're extrapolating from the Spanish influenza of 1919, because that's exactly what happened. There were 3 waves of the illness. The first wave was moderate, the second wave was severe, and the third wave was catastrophic and was probably responsible for half of the deaths that are now estimated to be 100 million. And then it went away. And we have no explanation for that either. And that was before we had any of the science and technology that we have now. So, other questions? Because I can't see questions here. Unfortunately, on my screen, I can't see questions. So I don't know if there's other questions. I've got a few critical care specialists here in the room with me on the second floor of Pickens. I don't know if there's any questions we need to throw out there for the audience. Apparently no questions. Wow. Maybe we're just having lunch. Maybe just having lunch. Okay, well, listen, thank you everybody for what you do. Remember, glass is half full. We're going to learn a lot about this disease and already look at what we have accomplished. We are coming together as hospital and medical centers trying to deal with a challenge that none of us have ever experienced in our careers. We had the most dire predictions that look to be less dire. It appears that we are flattening the curve. I encourage you to use technology, use the internet, learn what's going on out there. Feel free to follow me on LinkedIn. I try and post contemporary articles as well as scientific articles, as well as public health experts who are estimating how we're doing. I think we're making progress. I think 2020 is a year we're going to talk about for the rest of our lives. And it's my honor and privilege to be able to work with all of you guys as we move forward. So everybody hang in there, and we'll have another irregular update to follow. So good luck, everybody. Peace out.